crack on.
Yeah. Hello everybody, thank you for joining us. For those of you that don't know me, my name is Joanne Wright and I work in the support and information team alongside Louise Kirby. Just a few housekeeping points before we start. I can see you're all on mute, which is great. If you can stay like that whilst the presentation's being given, it just helps to cut down on background noise. As I just mentioned, we will be recording this webinar, so if you don't want your image to be seen, please turn off your camera. There will be an opportunity at the end to ask Professor Harding some questions. The way that we do this is if you just let me know in the chat function that you'd like to ask a question, and then at the end I'll ask you to put your question to Professor Harding yourself. Just it makes it seem a bit more like a dialogue, just works a bit better. Well, that's everything from me. I think I'll pass you over to Louise now, who will introduce Professor Harding.
Thanks, Jo. So we are so very pleased to be joined by Professor Richard Harding, Herbert Dunhill Professor of Palliative Care and Rehabilitation at King's College London today for our 10th Support and Information webinar in this format here at BCRT. So the role of palliative and supportive care in optimising the well-being of patients and families living with a life with illness is one that is so important to acknowledge. Palliative care can improve a patient's quality of life whilst also helping the patient and family to feel more satisfied with the treatment they are receiving. So in the context of a cancer diagnosis, palliative care may start soon after learning about a diagnosis and may continue throughout treatment and into recovery. So Professor Harding is going to discuss this approach, as well as reflecting on how to put the patient at the centre of decision making when a disease is not responding to curative treatment. So thank you so much, and I'll hand over to you.
Thank you very much, Jo and Louise. Thanks for the invitation to talk with you today. It's an absolute pleasure to be with you, and I really acknowledge the fantastic work that your charity is doing. It's really, really important. And your focus on research, of course, is absolutely crucial in identifying what matters to people, but also identifying the best ways to deliver appropriate care. So it's great to be with you. Now I'm going to start sharing my screen. And if you can let me know that all's looking good at your end. Was that great? Fantastic. So thank you. So quickly by way of introduction, so I'm based at King's College London in the Cicely Saunders Institute. So you'll see Dame Cicely in the top left there. Very interesting woman. She trained originally as an almoner, which was the old name for a hospital social worker. And in her work, she realised that the needs of people with advanced disease who are approaching the end of life weren't being met at that time. And she retrained as a nurse. And then her passion for care of at that point, care of the dying was so great that she really wanted to make a difference. And she was advised that the best way to do that was to retrain in medicine. So palliative care, by definition, is multidisciplinary. We believe in the team, but of course, Dame Cicely was a team in herself. She was social worker, nurse, and doctor. And we are based in the building below that picture of Cicely. The building was conceived before she died. She really supported us in achieving this vision. And we bring together research, education, and clinical care all into one building. So we work with patients to identify what matters. We conduct research to identify better ways to meet patients' needs. We deliver it back through our team in that building, and also we teach it on our MSc and PhD programs. So we have a real vision of integrating research, teaching and care into one building. So here again is Dame Cicely, and here I think is an oft-used quote by Cicely, which I think really exemplifies her vision for palliative care. You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you to die peacefully, but also to live until you die. So if you come to visit our building at any time, on the ground floor, as you come into the building, we have a supported information centre. Patients and families can walk in off the street, healthcare professionals can come and get advice. We have counselling rooms, therapy rooms. That's the first thing you see. You see that statement in large at the front of our building with a nice big picture of Cicely. And if you're interested in hearing any more about the life and works of Dame Cicely, There's a really nice Desert Island Discs on catch up on Radio 4 you can listen to. And also in the last couple of years, there was a Great Lives on Radio 4 on Dame Cicely, which was hosted by Maureen Lippman. So you can hear a little bit more about her work. So the vision of Dame Cicely is really what we embody in the Cicely Saunders Institute and our vision for all patients and families. So for people living with, most of this evidence is cancer focused, for people living with progressive conditions, there's clear evidence across a number of studies now on what matters most to patients and their families when they're facing a life-limiting and life-threatening illness. The main concern that people identify, and one of the most burdensome concerns, is good pain and symptom control. So pain is one of the most common problems, one of the most burdensome problems, but also a problem that we know that we can manage with good analgesia. Symptom control as well, one of the main problems that people find difficult to manage is breathlessness, and we've done a number of randomized control trials on how to better manage breathlessness, particularly through team-based approaches where we do things like integrate palliative care with respiratory medicine, physiotherapy and occupational therapy. The next main problem that patients identify is good family support and reduction of burden upon the family. Now, patients report one of their main concerns is their worries about the family. And in fact, we ran a study in the 90s with cancer patients in Ireland, and we discovered that actually the family psychological burden was higher than that of the patients. So good family support is crucial. And of course, people want to be cared for at home. So having a well-supported family member to avoid unplanned crises and things like unplanned admissions is really, really important. Next takes us on to the person-centered care agenda, and I'll talk more about that today. But really what's important is that the clinical team know what matters to you. What are your preferences and priorities for care? Having those listened to, having them understood, and having them recorded as well. So it's not just listening and knowing what matters to the patient, but make sure that the care you deliver is responsive to what you've heard. So really making sure our care is person-centered. So having a sense of resolution and peace, and I'll talk about that a little bit later on how we measure that and how we assess that. So understanding what matters to the patient, helping them understand what's important to them, having maybe their existential or religious needs met, making sure what matters for people's decision making is understood, giving people opportunities and time to prepare is really important. So that if death does come, and not for everybody, are we thinking about end-of-life care, but if we're thinking about what do you want for the rest of your life, doing that in advance of death is really, really important. So early discussions about what matters is really, really crucial. Maybe we'll have a shorter life expectancy, maybe a longer one, but thinking about what matters is important. And then continuity and well-integrated care is very, very important, not having to repeat concerns and needs, care being fragmented, not knowing professionals is really, really important. And again, I'll talk to you a little bit today about how we've gone about that in palliative care to make sure that we have holistic assessment that's team-based and communicated. So I was glad that Louise mentioned the word quality of life, because that's really, really important. It's at the heart of what palliative care aims to do. Here's a nice statement. There was a large interest from the US government several years ago. A number of us were in Washington for a big consensus project meeting. So what is the goal of palliative care? So it's for patients of all ages, any diagnosis or stage of illness. Patients may continue all life-prolonging disease-directed treatments. So it's not an and/or situation. We don't reach a point where there's a thought that nothing else can be done in terms of disease-oriented care, cease treatment, and then introduce palliative care. We don't need to take that approach. And the model at the bottom is a helpful way of understanding that. This is by somebody called Hawley, based here in the UK. You can find this in the BMJ, H-A-W-L-E-Y, Hawley. And here's a really nice thing, it's called the bow tie model. So we start with treatment being focused solely on disease management. That may decrease over time as pain and symptom control are introduced, and then we may move on to survivorship, so treatment may be successful. We may move into increasing rehabilitation and palliative care. We may move into hospice care, palliative care units, and end-of-life care, and then of course very importantly bereavement support for families who are left behind. So it's integrating appropriate care in line with patients' goals and of course responsiveness of treatment. So here's the WHO definition, which was developed in 2002. We've just completed a global consensus and Delphi round of consultations on a new round of definition making for palliative care, because this is around 20 years old now, and that's just been published. But currently, the WHO is using this one until there's a shift to a new definition. So WHO sees palliative care as care that's improving quality of life, really importantly, patients and the family. So palliative care absolutely sees the family as part of the unit of care. We're facing problems associated with life-threatening illness, and what we aim to do is prevent and relieve suffering, so anticipate suffering, so anticipate things like breakthrough pain, make sure that patients are given adequate medication if breakthrough pain occurs, making sure we early identify and assess things like pain and other problems. And these last words are very important. So in palliative care, we talk about physical problems, which are things like pain and other symptoms like breathlessness, constipation, psychosocial concerns, so anxiety, depression, meeting family needs, and spiritual concerns. And when we talk about spiritual concerns, we're talking about maybe religiosity and religious beliefs, but otherwise it may be more existential and personal beliefs about meaning of life and life goals. So we're talking about the physical, the psychological, the social, and the spiritual when we're talking about what palliative care does. So here's some just very basic summary of what palliative care might do. And this is again from the extended WHO definition, which you can easily find online. So one of the hallmarks of palliative care, which I'm sure many of you would recognise, is providing relief from pain and other distressing symptoms. And there are many symptoms which can affect people with advanced disease. It confirms life and sees death as a normal process. So we see life and death as normal processes, and we try to optimize quality of life through there. We're not trying to hasten or postpone death. It's integrating psychological and spiritual aspects of patient care into decision making and the care that we deliver. Really importantly, rehabilitation and occupational therapy are part of what we do, because we're offering support to help patients live as actively as possible until death. So things like physiotherapy and occupational therapy might conduct goal assessment planning. So what are your goals? How can we help you to achieve your goals? Many hospices will have, for example, gyms and have physiotherapists working in there. We do a number of studies in the department on things like muscle strengthening to help breathlessness. Family support is really important. One of the main challenges for people with advanced disease is unplanned admissions. So if something happens that's unexpected, or the family can't cope with the problem, or are overly anxious about patient well-being, you might have a hospital admission which wasn't planned. It's often not what the patient wants to be going into an emergency department. So helping families to cope, helping families to deliver care, but also meet their own needs as well. And that's really important. So a lot of what I've done is make sure that we don't think about families just as proxies for the patient. The family is not just there to say how the patient's doing, to observe the patient, to deliver care to the patient. The family is there in their own right as recipients of care to think about their own care needs and their own support needs. So I said earlier, using a team approach is really important. So social work, medicine, occupational therapy, physiotherapy, chaplains, there are a number of psychologists and counsellors, a number of members of the team should be there to meet the patient and family needs. And of course, if death comes, after death, bereavement counselling as well. We want to enhance quality of life, and that can positively influence the course of the illness, and I'll talk a little bit about that today. And the last thing that the WHO states is that really important message again, that it is applicable early in the course of illness, alongside other approaches which may be there with an intent to prolong life, such as chemotherapy, radiation therapy. And that was traditionally one of the main challenges, for example, in the US, that you weren't allowed to claim on health insurance for hospice care until the last 6 months of life, and you had to be willing to forego any other treatment. Now, that's not what palliative care does. In the UK, you can, of course, have a palliative care referral whilst you're pursuing potentially curative options and other treatments. So does it work? Well, absolutely. There are a number of systematic reviews out there. I haven't tried to put all of them into this presentation today. Number of reviews of home palliative care, number of reviews of hospital-based palliative care, showing that it does improve outcomes and costs. The number of reviews here that I've shown you are to really summarize some of the most important work that's been done globally in the last 10 years, show really high quality, large randomized controlled trials, mainly coming out of the US, showing that early integration of palliative care, not waiting until the end of life, can really, really improve outcomes. Now, this first issue, survival, is really interesting. The first large, big trial of early palliative care was done by Jennifer Temmel in the US. It's in the New England Journal of Medicine. And she showed that for non-small cell lung cancer patients, early palliative care had an average survival effect of 2.5 months, which is very interesting. Now, there's debate about why that was found, and not all trials have been able to reproduce that. Our breathlessness intervention studies certainly showed a survival effect, but not all trials are reproducing that. Early integration of palliative care also improves quality of life. It has a positive impact on the intensity of people's symptoms. It can improve depression. It reduces aggressive treatments at the end of life. It enables patients and their families to have better prognostic awareness, so they have better understanding of their disease, its progression and implications, better satisfaction with care, and better spiritual well-being. So there are a number of randomized controlled trials out there now showing this. They've mainly started in cancer, but now moving into things like heart failure. So what are the common goals? What are we trying to do in palliative care? So one of the goals is reducing over-treatment at the end of life, because the introduction of futile and very burdensome treatments is often not in the patient's interest. And if patients are fully aware of the options, it's not what people would always choose. Maintaining care at home is absolutely crucial. There have been a number of studies now showing that people want to be at home, so we maintain people there. Avoiding unnecessary emergency rooms. I was in a meeting yesterday. A PhD student, a doctor who's just doing a PhD in palliative care at the moment, and she was showing some data on the exponential rise of admissions to emergency department by people in the last 12 months of life, and in the last month of life there's an exponential increase in the number of people that end up in emergency rooms, and decrease in the number of hospital admissions. So I thought this would be quite a nice thing to share at this stage of the presentation. I have the utter pleasure of being on the board of trustees of Marie Curie, and I'm sure you all know Marie Curie very well. And on their website, they have these really nice common myths, and I just thought it might be nice to take a moment to look through these common myths. So myth one, if I need palliative care, it means I'll have to go to hospice. Now, actually, palliative care began with the model of St. Christopher's by Dame Cicely Saunders in South London, which was indeed the modern hospice model. But now actually your GP under the gold standards framework can provide you with palliative care. You can receive it in hospital, you can receive it in care homes. We've certainly got large research studies at the moment, program grant looking at improving end-of-life care in nursing homes. You can receive it in a hospice. So palliative care is not a place, it's an approach that enables you to get the care that you need at the stage that you need it, in the place that you need it. Palliative care, it means my doctors have given up and I'll no longer receive active treatment. I'll tell you that one of the best things that I ever learned was a colleague of mine, Dr. Liz Gwither at the University of Cape Town, who's been a palliative care doctor for many years. And one of the most important things she teaches is there is never nothing that we can do. That moment never arises. There's always something we can do. Something can always be done to improve your well-being. May not be curative treatment, but it can certainly be symptom relief and improving your quality of life and managing you to live well with your disease until the end of life. Palliative care means I'm going to die soon, so you can, of course, receive palliative care at any point in your illness. Some people have it long term for living with complex problems with a life-limiting condition. Others will just receive it in the last weeks or days. If I'm seen by palliative care, I'll no longer be seen by other specialists. Well, that's obviously not true, because you can receive it alongside the care you're receiving from your oncologist and anybody else that you're seeing. Palliative care in hospitals usually is a consultative service, so we don't often have palliative care beds in hospitals in the UK. We just have a consultation service. You go and see the patient and your team and talk through what might be some of the issues to help you live better. Palliative care is just about pain and other symptoms. Well, absolutely not. I think we've already talked today about palliative care being holistic and focusing on you and your quality of life. So focusing on what matters to you, what's giving you the most burden, concern in terms of your physical, psychological, social and other needs, and your spiritual as well. And palliative care isn't for family and friends. Well, palliative care teams do understand that the illness is having an impact on your family and your friends, and they will do all they can to help the people around you cope as well. And of course, by that, they enable them to support you. So those are some of the common myths from the Marie Curie website, which I thought were quite helpful. So I'd like to talk a little bit about the concept of person-centeredness. So the UK government has a national end-of-life care programme, and the NHS end-of-life clinical lead is Dr. B. Wee, who's based in Oxford and is doing fantastic work on the interface between policy and end-of-life care. And the goal of the national end-of-life care programme is this: it's to deliver personalisation and choice in care for people at or near the end of life. So this is a really important word, is choice. What matters to you? What are your priorities? What are the goals of care that are most important for you? Where do you want to be cared for? What do you want to focus on? So that's the really important goal here. Care needs to be personalised. And there's a really clear choice in England about where people would like to be at the end of life. We had a large EU grant a number of years ago that I led, and we surveyed almost 10,000 members of the public in 6 European countries and asked them, if you were seriously ill with a disease such as cancer in the last year of your life, where would you like to die? And 63% of people in the sample in England said they would like to die at home. From 1993, so there's a small typo there, we've also got some data from a Professor of Epidemiology and Statistics in our department, Professor Wei Gao. We've published some data in PLOS Medicine that showed from 1993 to 2010, hospital actually was the most common place of death for cancer patients, but that is declining. The national strategy is working, and the proportion of people who die in hospital in England is decreasing. So let's have a little think about what person-centeredness is and what it might look like. So there's a really nice definition from the Institute of Medicine that defines what quality care is, and it's very clear that quality care is person-centered care. So taking a holistic approach, not a medical approach. So palliative care tries to demedicalize your experience. It incorporates whole well-being, so what matters to you, understanding who you are as an individual. And I've seen really great practices with palliative care doctors on their first meetings with the patient bedside. Say, tell me about you, who are you, what matters to you? Really important questions. Understanding the context, how do you live, where do you live, how do you express yourself, what are your preferences, what are your beliefs? And of course, it's not only limited to the patient, understanding those things about the family around you as well is really, really important. Managing uncertainty, of course, is very, very difficult. To live with uncertainty is hard, and to clinically communicate and manage uncertainty is very difficult. It's emotionally challenging for patients and carers. And of course, communication is a common problem in healthcare. It's a complex problem between patients deciding what they want to know, trying to make decisions with complex information, which is given hopefully in a way that enables them to make informed decisions. Clinicians understanding what patients want to know, what they don't want to know, wanting to understand the point at which information needs to be appropriately shared. So communication is a huge, huge challenge. And an example of how we've tried to get around that is the Amber Care bundle, which we've been trialling in Guy's and St Thomas's hospitals in London. So understanding patients, so identifying patients on the ward who have clinical uncertainty and trying to raise awareness with patients and their clinical team of issues around prognosis. And we can show through this some feasibility work we've done that has increased awareness, having a simple intervention from the palliative care team to increase awareness of prognosis and have more discussions around decision making and patient preference. So there's some simple tools out there that we use. I'm sure many of you will know the concept of an advanced care plan. I had a little look on the British Medical Association website at the weekend to see how they defined it. And there's some nice patient-facing information on the BMA website that said it's a way of thinking about and recording what you want to happen to you if you become so unwell that you're not able to make decisions about your medical care or treatment for yourself at the end of life. It's a way of letting the care team involved in looking after you and those close to you know your views and what you would like to happen. So I think this is a really nice example of how you might try to make care more person-centered by understanding what matters and what you want when you have the chance to communicate it. So there have been a number of systematic reviews of randomized control trials of advanced care plan interventions that show actually for the patients it has positive effects on quality of life and also on enabling patients to have their wishes complied with. Families have better satisfaction with the care that they see being delivered, and it reduces family emotional distress and it improves their bereavement outcomes. And for the health system, if you have an advanced care in place, it improves costs because, of course, it reduces futile treatments and it decreases hospitalizations. So advanced care plans can really have an impact. So an important question when we're trying to take a person-centered care approach is what is your main concern? What matters most to you? So focusing on the person and not the disease. And that's really important, of course, when you've got aging populations and you've got comorbidity and multimorbidity, because, of course, an older person with cancer may be living with the cancer, but they may have other frailty, they may have COPD, they may have early stage heart failure. So really focusing on the person and not the disease really can improve the person-centeredness of care. So one of the things that we use routinely in palliative care and across a number of other clinical specialties as well is a patient-reported outcome measure, a PROM, was a simple way of being more person-centered. So by routinely asking simple questions about patient well-being and then using that information to focus the conversation, to focus the care, to inform decision-making, can really improve the quality of care and the patient outcomes. So one of my colleagues, Simon Etkind, who's a palliative care doctor and completed his PhD with us, conducted this systematic review on the capture, transfer and feedback of patient-centered outcome data in palliative care. So really asking patients PROM data, using that data in teams and feeding back that data into conversation and treatment can get better recognition of symptoms, more discussions around quality of life with the patient and the family, increased referrals to appropriate healthcare professionals, and improved emotional and psychological outcomes. But it's that feedback that's really important. I'll give you the example of the palliative care team at King's, where I work. In the afternoons, they use the palliative care outcome scale routinely with their patients. And in the afternoon, I see them with their multidisciplinary team meetings where they have individual patients being discussed on the screen. We see their outcome scores over time and it informs their decisions about treatment plans. So the palliative care outcome scale that we work with was developed in our team over 20 years ago. It's used by the multi-professional group, including patients. They're involved within the development, and we've got a really, really strong patient engagement program, and I'll talk to you more about that. It was originally designed for patients with advanced cancer across a number of settings, and we've done a huge amount of work over 20 years on validation of that, but also implementation, so getting it into routine practice to empower patients to be able to identify what matters most to them. And it's done in a small number of minutes. I use it a lot in Africa. Our African nurses usually use it in around 5 minutes. So it's a quick way to identify rapidly what matters, where do we need to focus on today. So the brief palliative care outcome scale measures patients' physical symptoms, psychological well-being, emotional and spiritual needs, and also understands their information and support needs. And it's a measure, really, what we call it measures is it's a measure of symptoms and concerns. And it enables patients to report their well-being. So we don't call it a quality of life measure because we want to make it very clinically relevant rather than a kind of conceptual measure, and it's way beyond the traditional focus on pain and symptoms. So we currently use it. I mean, there's a website there if you'd like to see more. We have a number of clinical decision support tools. We have different versions for example, for multiple myeloma. We have an MS version, we have briefer versions, we have patient empowerment modules, and it's endorsed by the Council of Europe as well to have the best properties. So we're very much about implementation for patient-centeredness. And here's an example of an item. Can you tell me over the past 3 days, have you been affected by pain? And the patients can score their pain very rapidly. And once the POS has been scored, the clinician and the patient can see where the worst scores are, focus their discussions there. So it's like being able to do a multidisciplinary or a holistic patient assessment very rapidly. I'd like to talk briefly about children and young people, which is very important and brings new challenges and new things become important. The Medical Research Council here in the UK back in 2009 identified children and end of life as urgent areas for patient-reported outcome measurement development. They saw it as a real priority. And a colleague of mine, Lucy Coombs, who is a paediatric palliative care nurse specialist at the Marsden. She did her master's with us and did a systematic review of outcome measurement for such children and found that there was no valid measure for children and young people with advanced disease. There was evidence that existing measures just don't reflect what matters to children and young people facing life-threatening and life-limiting illness. Very excitingly, my colleagues in Africa developed the world's first measure for paediatric palliative care. And I'm delighted now that we've got funding from the European Research Council to transfer that work from Africa to Europe. So now we've got a 5-year programme on paediatric palliative care outcome measurement to make care more person-centred and empower children to identify what matters to them most. Very complex area of work, and I'm delighted to say that we're working with Great Ormond Street, with the Evelina, with the Marsden and with King's Hospitals and a number of other sites now, including Leeds and Belfast on this project. So it's really exciting now to focus on ensuring children can benefit from this 20-year programme of work we've had with adults. And here's a review that was recently published by Eve Namisango from Uganda, a PhD student of mine. She did a review of symptoms and concerns among children and young people with life-limiting and life-threatening conditions. In that review, which was published in The Patient at the end of last year, we identified almost 14,000 studies, which we synthesized. 81 were retained in the review, and that review reports on just over 3,000 young people and children, over 2,000 family caregivers, just over 100 families and 900 healthcare providers in that review. Although the very interesting observation is that within that, no young person contributed to 30% of those studies. So there's a real concern about children's voice in research when they have a life-limiting or life-threatening condition. So a third of those studies had no child's voice represented, and that's a real focus for us. So in Eve's review, what does the evidence tell us matters to children? So in the physical domain, we identified pain, which is related to both the disease and the clinical procedures that they may have to undergo, and that was very much associated with fear and anxiety. And I know clinical teams are incredibly talented at managing procedural pain for children. Problems with their energy levels, problems with nausea and vomiting, dry mouth, weight loss, drowsiness, problems with swallowing, shortness of breath, eating, sleeping, and being able to communicate. And very much a lot of our work is focusing on how you enable children to identify the concerns when they may have developmental delay or communication issues. Psychological concerns, real emotional problems for children, mood change problems, cognitive problems, behavioural problems, anger, anxiety, and also the psychological strain of trying to protect their families. That was something that came up in the literature. So that's a really interesting question for us about how you empower children to self-report their concerns and what the data sharing and ethical issues are with their families. The psychosocial domain is very, very interesting for these children, a real sense of being different and wanting to be normal. We're having a huge amount of meetings at the moment about how we interpret this, because this feeling of normalcy and wanting normalcy like other children is really very powerful and key. Issues around visual stigma of their disease and its management, issues around body image, isolation and need for fun, issues of isolation and access to education, access to leisure, access to friends' networks is crucial. And families really struggle, of course, to manage these problems. There are family concerns as well. It's very interesting when we think about existential concerns for these children. They would never label that as such, of course. There are a number of concerns they report which you would put under a heading of existential worry. So they're feeling at peace, their own worry, their expectations for their life. What can I expect and what can I achieve? A positive message of the gift of life, children really valuing what they saw as the gift of life, and the growth of their own resilience. So children could really use language which represented a sense of personal growth and resilience. Other problems reported about decision making and how you make decisions with children, concerns about models of care provision, and also issues of finance, because of course advanced disease brings a lot of financial strain to patients and families. So I want to talk briefly about patient and public involvement, which is absolutely at the heart of what we do in palliative care research, and also in the care that we pioneer in our research and try very much to deliver to all of those who need it. So we started off with some expert consultation with patients and families who really wanted us to focus from this research we published. They said they wanted early involvement in research from the outset. They wanted to make sure that their involvement was meaningful and impactful, and that we needed to focus on diverse ways of contacting, because of course in palliative care some people may be frail and sick and unable to participate in particular methods of involvement. So we needed diverse ways to involve to ensure flexibility. So we worked with them to develop an online PPI forum, and Lisa Brighton in our department recently published the work on that. We wanted to know if it's functional, feasible and acceptable, which were the goals for our online forum. How does it work? How does it engage people? Does it empower people? And what's the impact? And that's really been the focus of our PPI work. And some examples of what we do, and I'd really like to acknowledge the work of Hallie in our department, and also Dr. Catherine Evans, who's the PPI coordinator. We have a Dragon's Den, which I presented to, which is fantastic. Go into a room, we have our PPI in the room, 10 minutes, present your project, sell your pitch, get your feedback. The feedback is always incredibly helpful. And then also we usually get a few people who will identify themselves as being interested and then work through us on the project application, the grant application, and then stay as paid PPI members on the grant. We have an online forum which I think has over 60 members, so you can send materials out, identify interested parties and get feedback. And then we get named applicants all the way through the grant. Review of materials is really, really important. So we've got consent forms, information sheets, questionnaires. PPI really input into that, which is fantastic. We focus on training opportunities as well. So we work with our PPI members to understand their training needs, and we get training for them through our Biomedical Research Centre, through the Clinical Research Network, and we're part of an Applied Research Centre and ARC through National Institutes of Health Research. I'm delighted to say actually last year we won the prize in the ARC for Best PPI, so that was really exciting, and our PPI members were absolutely thrilled by that, of course. And there's a website there and you can understand a little bit more about the PPI that we're doing. So the last thing that I would really like to share with you is a good story. You know, the modern palliative care movement originated in the UK. We started with Dame Cicely on the first slide. The UK is the best place in the world to die, according to The Economist. They did a review. They've just redone this. I haven't seen the new data yet, but it's a metric of, do you have good end-of-life policy? Is it integrated into the health system? Is there a vibrant hospice movement and community and public engagement in palliative care? So the UK is the best place to die. You can die well in the UK, and you can live well until you die. So that's the really important message. And I would just share with you some resources that I recommend that you look at, both resources for healthcare professionals and also resources for patients and families. Marie Curie has excellent resources, and I've drawn on some of those today. Children, I would really recommend the work for Together for Short Lives, and we work very closely with them. Fantastic organisation. We have a number of resources at the Cicely Saunders Institute, and I would also urge you to look at our COVID-19 pages on the institutes. We've done quite a lot of work on palliative care in the COVID-19 challenges. NHS UK website has palliative care pages. Patient.info has good information as well. The European Association for Palliative Care is fantastic for patients and professionals, and the Association of Palliative Medicine here in the UK, led by BWE, also has excellent resources. So there are many, many places to look beyond this short presentation that I've been able to give to you today. So thank you very much for listening.
Right, thank you so much, Richard. That was fantastic. If I could just ask you to stop sharing your screen. Yeah, that's brilliant. That's wonderful. Thank you so much for that. We haven't actually had any questions at the moment, but I've got one that I'd personally like to ask you. From what you were saying, a patient on diagnosis could access palliative care. It can run alongside their active treatments. Mm-hmm. So if that's the case, how do we change the conversation around palliative care being end-of-life care, which I think is what the vast majority of the general public associate with palliative care?
Yes, I mean, there are endless debates about terminology. People talk about supportive care and layers of additional care. I mean, of course, palliative care is from the point of diagnosis to the end of life if it comes. And of course, at the core of all of this is the fact that society is death denying. And my concern is that we talk as if death will never come. And of course, whether you're living with cancer or not, the lifetime prevalence of death is 100% for all of us. The important thing is, we may not need to focus on the terminology of palliative care, but we can focus on what it does. So at the patient level, you may not in your first conversation say, let's talk about palliative care, because that probably wouldn't be appropriate, but we can talk about what matters to you. We can talk about, let's think about the future. You can talk about what's bothering you most right now. Are there any symptoms that are really troubling you alongside this? These are our goals of care. Let's think about what we may need to do to support you as we attempt to do our best to manage the disease. There are all kinds of issues, language that you can use to focus on the problem and the care rather than the terminology, I think.
Okay, yeah, that makes sense.
Okay. Shall I ask a question? I can watch the chat box. So you mentioned you had helped to develop some resources around palliative care and COVID-19. I wondered if you could just expand a little bit on some of the ways in which palliative care has been affected by the pandemic.
Yes, I mean, of course, there's from the patient perspective and the clinical perspective, the problem for patients, of course, is that patients with advanced disease, of course, can already be quite socially isolated because you can have reduced function. So there are massive issues about function, and there's the ability for stressed families to be able to cope well at home, particularly if you don't want to have an admission because of the risks of COVID. So there are all additions of anxiety as well. There's issues that often people don't want somebody coming into the home, and community teams are absolutely crucial in maintaining people in the home. So one of the challenges we've had is, actually when you've got a vulnerable patient or a vulnerable family, actually not wanting people to go into the home. I mean, palliative care teams have been incredible. At King's, we've been a major COVID centre, and the palliative care team have been absolutely incredible in supporting the rest of the hospital in symptom assessment, in difficult conversations, in de-escalation and establishing appropriate goals of care, in supporting family bereavement. I mean, there's been a lot of bereavement to manage. So there's been the clinical response to the existing patients. Now we've gone, well, we've had a dip then, we had fewer referrals. Now this is coming back up again, and we're just starting to manage our first COVID deaths again, or the clinical team. When I say we, I mean the institute. So the issue is how you manage people at home, and you keep them at home when sometimes an admission might be appropriate, but people don't want to do it, and also when people don't want to be seen at home. So most of the care is done by telephone, of course, now, because palliative care is a consultative service, so it's doing telephone assessments, and that's where things like outcome measurement can be really key. In Africa and India, we've been using a lot in the last year of mHealth, so putting outcome measurement onto phone apps, so people in rural districts are able to get their community healthcare workers to identify concerns.
Okay, thank you.
I think we've got a lovely comment from Jill there. Thank you for sharing that, Jill.
Yeah, that's wonderful. Richard, I was just going to ask you as well, are there any criteria for the patients and families that can have access to palliative care, or is it available to everybody?
Well, I mean, that's a really interesting question about access to palliative care, isn't it? So the important thing is palliative care skills, so being person-centered, assessing pain and symptoms, communication, should be trained in all healthcare professions, and everybody should be able to have those conversations. So the palliative care team should not be seeing all people with palliative care needs. Palliative care teams should be there to train and support, and if you've got some complex pain that doesn't seem to be responding, or some complex decision making, then palliative care should be able to be referred to. But actually this idea of referring to palliative care, when should you have palliative care, is probably a little bit of a false challenge, because your oncologist should always be thinking, how do I best handle realistic goals of care? How do I best handle making sure that I understand what matters to this patient? Have I checked their pain? Am I managing their symptoms optimally? So this, so palliative care should be part of what you do as care, because it's good care. And then the question is, when should I refer to palliative care? So yeah, I mean, it's interesting. I had personal experience. Year before last, my grandmother was dying, so went to the ward. It's very clear her pain was not being managed. She was expecting to die that day. I kept repeatedly saying, she's clearly in distress, pain's not being managed, this syringe driver has not appeared, please phone the palliative care team now. Had quite a fight, phoned the palliative care team, and they quite rightly said, absolutely not, we should not be coming out to put up a syringe driver, you can do that yourself. And that's what we need to be making sure clinicians are doing. Hospice physiotherapist, I see.
Yes. I think you need to read through.
Yeah. Well, that's interesting. I mean, I guess C. Hegarty, sorry, I don't know your first name, I apologise. But Claire, I mean, I guess the interesting question is, what conversation has been had before they get to you, isn't it? That would be my thought. So if the referral's made, so you hopefully some of that shock and anger has been dissipated because there's been a prior conversation. You would hope that somebody hasn't made a referral without a full and frank discussion about what that referral means, who's going to call you, how they're going to introduce themselves. Because I think you're right. You trying to explain stuff on a first call is quite challenging. So the question is, has somebody been rather uncomfortable about making that referral frankly and kind of passed on that initial conversation to you?
Okay. We've also had a question from Vicky Vinada. Vicky, would you like to ask your question to Richard?
Yeah, sorry, I was just trying to unmute myself. Well, I was wondering, because obviously you mentioned that both the patient and the family are important, and the family is an entity, it's not just a company thing. how do you not prioritize, but make sure that both the wishes of the patient and the family are taken into account? Because sometimes they could be very different. And I was wondering, how do you approach that?
Thank you, Vicky. That's such a fantastic question. And most of my early work was on family members. Now, first of all, there's a cultural dimension to this. I work mainly in global health, and there's a cultural dimension. So largely Western European cultures are quite individualized. So it's quite a normal thing to do something like an advanced care plan or ask the patient, and the patient can be individual. Whereas in other cultures I work in, and migrant cultures to the UK, there's much more family-based decision making. So the idea that you individually make decisions on your own is quite an unusual idea. So decision making and prioritization is culturally different. The other thing is, you're absolutely right, that the patient and the family may have very, very different wishes. The patient may wish to be at home, the family may be unwilling or unable to do that. So one of the things that I think is very important is making sure that you spend time to do separate assessments.
Okay.
So I think making that time to speak to the patient and the family separately is really important. And it's interesting, nurses always talk to me about doorstep conversations. That they'll have been in the home with the family, been there for an hour, everything's discussed, and then when you go into the door, family member will step outside and they'll say, this is what I think, this is how it really is. So making sure, because if we really do see the family as part of the unit of assessment and care, excuse me, we need to make sure that we give them time to identify their concerns. And then, of course, the problem is, at the end of life, you're entering into a family culture which has existed for decades, and sometimes you can't mend a family's challenges in the last weeks and months of life. But what you say is really, really important.
Thank you.
Thanks, Vicky. Do you see there's a message from Joe saying that the Marsden now, they're calling palliative care, the palliative care team, the symptom control team, because the patients find that better to understand. It's interesting, but I would have thought that doesn't actually represent what the palliative care team do. It's not just about symptom control.
Yeah, I mean, I've been out with clinician colleagues who've done that before as well. So I'm from the symptom control team. We play a lot with terminology, and I've seen many different directions attempted. My concern is, as you've just said, Joe, my concern is patients respond to what you think you want as a clinician. So I think one of the main challenges, and most of the research I've been doing for the last decades, is patients will share what they think you want to hear. So they won't bring their anxiety or their throbbing pain that's been problematizing them for ages, or their sexual dysfunction or their constipation, because you haven't asked them. So if they think you're not interested, they definitely won't take a holistic approach to what they tell you. So my only concern would be, by saying I am from symptom control, the message is we're going to talk about symptom control and nothing else. It gives you a job then to make sure clinically that once you're in that conversation, you move way beyond that, because I think we sell ourselves in our terminology, really.
Yeah, absolutely. Just a response from Catherine. Sorry, I called her Claire before. It's Catherine Hegarty, the hospice physiotherapist. That's exactly the point that Louise and I were making earlier, Catherine, that you want to talk to patients and about palliative care, but you don't, because of the connotations that people have around that, you don't want to scare them, or they just won't engage with the conversation. It's a very tricky one. So I think we've got a question from Jill as well, just saying, if you had a patient with dementia, no health and welfare power of attorney, would the family be able to still have a say, or would it be taken out of their hands? What would happen in that situation, Richard?
Well, I mean, clinicians make best interest decisions, don't they? So absolutely, in decision making, you must take family views, and you must seek family views, but clinically, and if there hasn't been an advanced care plan, there hasn't been a decision made, then clinically a best interest decision will be made. And of course, you will make an assessment of there'll be a capacity assessment, and lots of the complex work, of course, in palliative care and nursing homes and older people is about capacity. But if there is nobody who has power of attorney, the clinician will make a best interest decision. And of course, somebody's best interest is taking account of family's views. You know, you can't do best interest without family view. They're not mutually exclusive.
Yeah.
Yeah, absolutely.
I had something else to ask. Is there a specific criteria that a patient must fulfill to qualify for palliative care, other than the nature of the illness? So could someone be very, very active, still living very, very well? I think we've sort of answered this, but just to kind of clarify, is there anything specific that they need to be doing or have?
I mean, the first thing is, of course, every clinical team will have its own referral criteria, so everybody's going to act slightly differently in who they see. And it's interesting, I mean, I would really bring you back to the conversation we've had with Joe. It's interesting that when can I access palliative care, because that really reveals the fact that it's not perceived to be integrated into your cancer care.
Yeah.
It feels like we need to have a separate discussion and bring somebody else into the room, where actually it should be part of what we do, until there's something complicated where the cancer team will say, actually, this pain seems to be problematic, or this symptom, we're not managing this breathlessness, or there are major communication and decision-making challenges which I feel I can't resolve. Let's bring in the palliative care team. So, I mean, it's probably triggered by a specific unresolved problem more than anything.
Okay, thank you.
Okay, well, I think that's it. There don't seem to be any more questions. So all that's left for me to do is to say a very, very big thank you to Richard for a wonderful presentation. Thank you so much for coming to do this today for the Bone Cancer Research Trust. It's been fantastic. And just to let you know about our next webinar, which will be on the 5th of November, and it's with Dave Harley, who is a long-term Ewing sarcoma survivor, who's going to talk to us about his experiences of being diagnosed and treated almost 40 years ago. So it should be really interesting, and it'd be lovely to see you there. Okay.
Thank you all. Thank you.
Thank you so much for being with us, everyone.
Bye.
Oh, is he just gone?
No, we're still here. We're still here.
Oh, sorry. Yeah, the one more question. Sorry, it's Jo again. So,
Yeah, I can see it.
yeah. So we look after prostate cancer patients, and we have quite a lot of questions because we refer a lot of our patients to hospices. Because we're a trials unit, we do have palliative care, of course, at the Marsden, but we refer our patients onto the hospices, and we get questions so often because if they haven't got specific symptoms, then we are rung up and questions as to why their patients need palliative care. And they're asking why we want to refer them if they haven't got specific symptoms. And when we say they need the psychological support, and like our prostate men, they have so many other issues as well that are ongoing for many, many years, but we struggle to refer them to the hospices, and we're questions as to why we're referring them. So we near enough have to say that they've got like uncontrolled pain, or and if you say they've got anxiety, they are going to be deteriorating in the next, they could be deteriorating the next month or so. But if they haven't got symptoms at that time, we're being questioned, which is really, we usually win and we can normally put our point across, but it's very difficult. They're not, we can't just write that they got anxiety and they need palliative care support because they are deteriorating. If they haven't got the symptoms, that we get questioned.
It's very tricky.
That's very interesting. I mean, the first comment I would make, Joe, is you probably know this already, but a major challenge is, hospices only get 1/3 of their funding.
Yeah.
Centrally. So 70% of hospice costs are raised through charity fundraising. So I think that's the first challenge you face, is that hospices are under enormous pressure. So you probably get a bit of pushback for that reason. I mean, it'd be interesting to have a conversation with the hospices in your, I mean, how many do you refer to?
Oh, lots, because we're on such a wide area, because we're trials. They're very, and some like the most ones probably to us are Princess Alice, St Raphael's, St Catherine's.
Yeah.
But a lot of them, like a lot of our patients are from Essex, and St Helena's and that are really, really good. We can ring, the consultant rings us up and we talk to her, and then we don't have an issue. But the local ones, I mean, St Raphael's and St Christopher's,
yeah,
I think they've got such a wide area of patients that for them they have to question as to why we need it.
I mean,
Especially, and they question us as well, because they're still on treatments and they're still seeing us. Of course, they're questioning why they need to be involved when we're still seeing them as well.
Yeah, yeah. I mean, the first thing I would do is I would amass the referral criteria for each one, so that when you're making your, because you're dealing with a lot of hospices. I mean, do you have a file of the referral criteria for each one that you refer to?
Yes, yeah, we do, and we're, you know, that we probably do such good referrals because we know them very well. We send everything. We don't just send the form. We send, you know, we send a lot, and we do have the criteria. And most of the forms are okay. It will say psychological support maybe, but some of them don't have anything. And you know, it's just when you get questioned, we usually get there, and we haven't had anybody refuse us. It's just not, you know, sometimes it's hard when you're rung up and you're questioned by someone that's obviously, you know, needing palliative care for holistic reasons, for family, them, because they haven't got a symptom doesn't mean they don't need palliative care.
No, I mean, to be honest, it sounds like you're very skilled at making your referrals and getting them through. I mean, it is a challenge, and I think the other thing is the hospice movement, because it's been under financial pressure, does have to constantly question what its role is. That's the other problem. And you know, I'm sure they'd like to be able to take more referrals, but it's a constant question, and probably each hospice has a slightly different understanding of what their role is, to be honest. I would say, but I mean, I would congratulate you on making such a good job of getting all of your patients through.
How many sorry, you go, sorry.
No, I've got nothing else, thank you.
I was going to say, how many referrals do you think you make weekly or monthly? Is it
Ours aren't that many, because I just do prostate. We are a trials team, but I think because we have a phase 1 unit as well that we're separate to, they probably refer every single patient, and because they're on a phase 1 and they're more likely to not respond to the treatment, they're probably never questioned. But because we're on, you know, because we're a slightly different, we're just prostate and we're phase 2 onwards, so some of our patients can be on you know, trial medication for years. So I can understand why they question it. It just, and I think with COVID as well, it's just getting harder and harder.
Yeah, no, I agree.
Yeah.
And I think it's, if you've got patients that are on very, very long-term care, I think hospices have less interaction with patients very, very long-term. I think that's probably not the model that they've pursued.
No.
Yeah. Could you not refer them to the palliative care team at the hospital, Jo?
We can do. We do if, you know, when pain really is an issue and they're not getting always the support. But on the whole, our palliative care team will say you need to refer them to a hospice.
Right, okay.
But they would never say no, but we might ring them up just for advice for ourselves to what to ask the hospice to write up, or what to ask the GP to write up. So we use them more for advice than we would, or if someone came in and their pain was really bad, or they're vomiting or something, then we would ask their advice more than use them as a routine access. Yeah, but we can do.
Right. Okay. Well, I'm sorry I didn't see your question till the last minute.
Oh, no, that's all right.
Okay.
Thanks,
Right. Okay. All right. Well, I think we are actually definitely finished now. So thank you so much for joining us, and hopefully we'll see you at our next webinar on the 5th of November.